Good evening, everybody. We're going to be starting in the next couple of minutes. Thanks a lot for joining. I'd like to welcome everybody to our session. We'll be starting in 1 minute. All right. So, good evening or good afternoon to everybody who's joined us. We're really excited and keen to present this update in the Canadian Hepatitis B guidelines. I'd first like to thank everybody who's taking time out of your busy day to join us. I'd like to thank the individuals who helped to organize this, our speakers, and everybody who contributed to the guidelines. Specifically, I'd like to acknowledge CASL and AMI for providing their very, very helpful feedback in the development of this, as well as the Canadian Hepatitis B Network, and also GSK for providing some support to help with the logistics. Before we get into the talk, I want to remind everybody that there's two ways that you can participate this evening. You can put your questions in the chat box, and then when we're done, which we anticipate will be in about an hour or so, then you can continue to put questions into the chat box, or you can participate in an open Q&A. I will be monitoring the discussion, and then our group of esteemed speakers will try to tackle all your questions. So with that, let's begin, and we'll first welcome Dr. Carla Kaufman from the University of Calgary to get us started.
Thanks, Curtis. Thanks for the introduction. That's great. And it's a pleasure to see everybody here this evening. So the purpose of this webinar today is to update everybody with the new Canadian Hepatitis B guidelines and specifically highlighting the main changes from previous guidelines that were published in 2018. And for people to take this and see how they can adapt it to their own clinical practice, recognizing that there are always nuances when it comes to individualized management of each patient. Next slide. So you'll meet many of the members of the committee this evening, but I'd like to introduce the committee and the rationale behind their selection. So Dr. Carla Oshway was the chair of the guidelines. She's a retired former chief scientist at the National Microbiology Lab, chief of bloodborne virus detection. We had a mixture of hepatologists and gastroenterologists, as well as infectious disease specialists and a pediatric hepatologist on the committee. We selected representatives from five provinces. And importantly, for these guidelines, we wanted to include somebody who could provide a community perspective. And thus, we invited Jennifer Van Getup, the Director of Action Hepatitis Canada, to provide the feedback and perspective from the community and the importance of patient-partnered care. Next slide. So I believe this is for Dr. Cooper to be reviewing and updating. Is that right, Curtis?
Well, I can do this, sure. So, couple of things to keep in mind. The last guidelines were in 2018, so there were specific sections in these guidelines that we really focused on updating. Uh, Remember that these recommendations are based on expert opinion, the most recent literature, and international guidelines. We conducted a series of iterative discussions and tried to seek consensus both amongst our group and amongst the broader community. The decisions and ratings and recommendations are consistent with the Oxford 2011 level of evidence. The updates was reviewed, modified, enhanced by patient-centered engagement throughout the process, and this was led by Action Hepatitis Canada. And then the documents were reviewed by AMI and CASL members. So we feel as though we really went the extra mile to produce a document that really does reflect a consensus of Canadians who are either living with or have an interest in hepatitis B. Next slide. So I believe this is back to Carla.
Sorry, some confusion back and forth here. So the key points for the new guidelines that were different from before was emphasizing universal screening. So not just risk-based screening, but a one-time single screening of all individuals for with the triple panel. So hepatitis B surface antigen, hepatitis B surface antibody, and hepatitis B core antibody. We also stress the importance of universal vaccination for those that had not previously been immunized. So this would include many adults that would have missed the childhood immunization program. And as Dr. Fung will talk about, we discussed about expanding treatment in general, just starting more patients on antiviral therapy. And we emphasize the continued need for investment in hepatitis B research. And as I've noted, with the inclusion of a patient partner or a person from the community to emphasize the importance of patients being at the center of decision making with their values and preferences prioritized. So, okay, so I think this is for Jennifer to discuss.
That is correct. This is Jennifer from Action Hepatitis Canada. So take it away.
So much. And thank you again for including community in the development of these guidelines. It's much appreciated. I think we're familiar now with the World Health Organization call for Hep B elimination and the global health sector strategy to eliminate viral hepatitis as a public health threat by 2030. As of 2022, there were an estimated 254 million people living with hepatitis B globally. 86% were unaware of their infection and 97% were not treated. So lots of room for improvement. Two of the goals from this strategy are to reduce new hepatitis B infections by 90% and reduce hepatitis B related mortality by 65%. Next slide. So here at Action Hepatitis Canada, we do a progress report every other year. So this was a progress report year. And so we were able to align our recommendations with the updated guidelines. So the current status for Canada with the information that we have is that it is likely on track for hepatitis B elimination targets. And I'm going to share here some information from the Public Health Agency of Canada, mostly from 2021. We do not have subnational data at the provincial territorial level to adequately determine status of individual provinces and territories, unfortunately. So it's not the next slide, but if you could just click through. Or can I? There we go. Thank you. The estimated number of people living with hepatitis B is 262,000 in Canada. This is a new number. We didn't really have a strong prevalence estimate until last year. Unfortunately, though, the data on new case rates was not available. But the target for 2025 is that there would be no more than 11 per 100,000 in the population. And for 2030, the target is no more than 2 new cases per 100,000. For diagnosis, at a national level, it looks like we're doing pretty well for the targets. As of 2021, 58% of people who have chronic hepatitis B in Canada were diagnosed. That's pretty close to the 2025 target of 60%. And then a little ways to go to the 2030 target of 90%. Click one more time, please. On Hep B prevention, thank you. We're at 89% of 14-year-olds that have received 1 or more doses of the hepatitis B vaccine. The target for both 2025 and 2030 is that 90% of children would be vaccinated. This number changes quite a bit in Canada if we talk about babies instead of 14-year-olds. And that would be more aligned with the World Health Organization recommendations. So we're going to talk about that on the next slide. If you click once more around mortality, we have 274 known deaths attributed to hepatitis B in 2021. The targets for 2025 is a rate of less than 7, and for 2030, it's a rate of less than 4. In 2021, with the data that we have, which I think we should take with maybe a grain of salt when it comes to Hep B mortality and the way things are reported, is a rate of 1 per 100,000. So based on the data that we have, it looks like we have reached that target ahead of schedule. And as I mentioned, the recommendations in our progress report this year align. The recommendations that we made to the federal, provincial, and territorial governments all align with these updated guidelines that we're presenting tonight. Thank you. Next slide. Just to touch on the vaccination, this is always a point of a little bit of embarrassment when we speak to our colleagues internationally. Both the United States and Mexico and many, many, many other countries follow the World Health Organization recommendation that first dose is given within 24 hours of birth. In Canada, we do not have harmonized guidelines for that. So what we have is 1 province and 2 territories following those guidelines. And then we have 1 territory and 4 provinces that are vaccinating at 2 months for that first dose. And then we have 5 provinces that still have their vaccination happening as part of the school vaccination program. So happening around grade 6 or grade 7. So when they're 11 or 12 years old. And as we all know, if we were actually vaccinating babies, that would be the #1 way to make sure that we are to eliminate new cases among children who were born in Canada. And that's it for me, I think. Thank you.
Great. Thanks a lot, Jennifer, for setting us up with the epidemiology of hepatitis B in Canada. So just going to talk a little bit about the philosophy that guided our development of the 2025 guidelines. We wanted to keep things simple. We recognize that hepatitis B can really confuse and confound both patients and people who are and healthcare providers. So we really made an effort to try and streamline and simplify our recommendations, and I think you'll see that in our presentation. We also recognize that hepatitis B is often not a black and white condition, and so we tried to build in some consideration for some of the nuances, in particular the gray zone patients, which we'll talk a little bit more about. With that in mind, this is not a one size fits all document. We try to consider the individualized, or we try to create an individualized document. And we really wanted to uh, try and make treatment of hepatitis B a little bit more permissive, and so that that's reflected in our guidelines. And as has been suggested several times already, we wanted to keep our patients in the middle of the of all our considerations, so that what we're doing makes sense and works for the in the lives of people living with hepatitis B. Next slide. Um, there are lots of other guidelines out there. We want, and everyone is familiar with the World Health Organization guidelines. There are some important differences about what we're offering in the CASL guidelines for Canada and the WHO. It's important to recognize that the WHO is really focused on low and middle income countries, in contrast to Canada, which is considered a high income country. The target audience for the WHO are national program managers who are trying to address nation and region-wide concerns related to hepatitis B, whereas the CASL guidelines are focused on healthcare providers. The approach is more of a public health model with the WHO. Really tries to be simplified and standardized, whereas this document is, as I've said before, it tries to emphasize the nature of hepatitis B at an individual level and tries to offer multiple treatment options. As far as the formulation of the recommendations, the WHO is really heavily dependent on the grade system of assessing recommendations and quality of evidence. We used a more flexible, permissive approach for our recommendations, and and then as far as the committee representation, ours was more focused on healthcare providers and the community who all come from high income countries. Next slide. So there's quite a bit of information in the document. We're not going to present every line of information. We're going to try to focus on the stuff that we think is new and different and important to our patients and to our practice. We're not going to spend a ton of time talking about the differences between EASL and AASLD guidelines and ours, but we'll touch on it where it's relevant. So there are some notable differences, especially with the AASLD guidelines, but nothing that we would really say is a major, huge departure from what our colleagues across the globe I think is the appropriate approach for hepatitis B. Okay. And just remember, these are guidelines. The guidelines are a starting point for the practice of medicine, not the end point. Our mandate was to review and the available evidence and make recommendations in the Canadian context with a focus on patients. Bit of a disclaimer, we're not responsible or liable for service offer or capacity in different laboratories. and we're not responsible for the accreditation of some of the tests, and specifically point of care testing. And we recognize that there's differences in provincial and public health policy depending on the jurisdiction. So next slide. So these are the key sections of the guidelines. As I said, we're not going to cover absolutely everything, but we are going to touch on the major changes in our guidelines, and with a real emphasis on the hepatitis B treatment indications, which Scott will be talking on shortly. Next slide. So, with that, it is Hin Hin Kuo time. So, welcome from the University of British Columbia.
Thanks, Curtis. So, as Jennifer already mentioned, I mean, Canada not doing too bad in terms about working towards the WHO elimination goals, but still only have 5 years to work towards like screening like close to 90% or diagnosing 90% of the patient with Hep B. And then in recognizing Canada, like the population, closer quarter is from immigrants. So the latest guideline, we're moving away from risk-based screening to universal screening for all adults, defined by over 18 years old in Canada, that we should be do a one-time screening for Hep B using a triple serology, basically testing for surface antigen, the surface antibody, and the core antibody. And in individuals, we suspect they have ongoing risk activities and persistent risk of Hep B infections. We should think about periodic screening as well if they're not already immune. Now, we recognize that in the low prevalence, sometimes Hep B populations, sometimes by doing this triple serology, we will pick up some kind of false positive isolated core antibody, or if someone, they have resolved Hep B, but they had kind of waning immunity, you may see just anti-HBC, the core antibody positive without a detectable surface antibody. So just something to be aware of. Now, by doing this universal screening, I think it's a new thing. We're moving away from risk-based screening. That's probably an area for research that we encourage to be considered doing some cost effectiveness modeling to kind of continue to support this kind of universal screening model in both provincial and national level. And I know in the practice, we sometimes see multiple tests have been done. So ideally, if there's some coordination of the EMR in kind of like provincial or international, we can hopefully avoid duplication of tests and increase the efficiency. Next slide. So this is just to highlight over the last 15 years. So this is the CDC update recommendation. You can see back then, definitely risk-based screening, we're just checking for Hep B surface antigen. And now basically our guidelines similar to the CDC recommendations. We do a universal screening at least once in all adults using the triple serology. And in certain populations, so for any kind of new pregnancy, and population at risk, such as like those incarcerated individuals, if they had like STBBI and a history of Hep C, like in HIV, so definitely should consider screening if they ongoing risk activities. So maybe you have to do it more than once. We also recommend Hep B vaccinations in all adults from 19 to 59 years old. This is based on the CDC recommendations. Next slide. Now, Hep D is the most severe form of hepatitis, and you can only get hepatitis delta when someone has hepatitis B, infections defined by positive surface antigens. So we definitely, again, recommend screening all Hep B patients for one time, do an anti-HBV antibody test. Now, individuals, you again have a kind of concern about some persistent risk for hepatitis delta, or if you have a clinical profile, such as if someone have Hep B, but again, not very high viral load, defined by less than 2,000, but for some reason, the liver enzymes are very high, so you're thinking this must be more than just the Hep B causing this kind of liver inflammations. So if you kind of concern, sometimes you might think about repeating the hepatitis delta antibody testing. Now, the testing for anti-HBV antibody should really be performed using a very sensitive assay, more than 90% sensitivity and more than 99% specificity. Now, having a positive anti-HBV, the antibody, doesn't necessarily mean that person have hepatitis delta infections. So we recommend doing reflex screening, check the delta RNA to confirm that indeed that person had the active hepatitis delta infections. And again, this because there's many variation in all the assay, you definitely want to send it to a specialized lab, such as the National Microbiology Laboratory. So I know many, even provincial lab, know how to send the specimen directly to MML to do further testing to confirm that indeed that person has a positive RNA or not. Next slide. So it's really difficult to get a true sense of the prevalence of hepatitis delta in Canada, partly due to kind of suboptimal kind of awareness and inadequate screening up to date. But we had kind of 4 fairly recent study published spanning from 2022 by the Canadian Hep B Network to up to the last year in 2024. And publication kind of get an estimate about what is the current Hep B population in Canada. But as you can see from all the meta-analysis and literature review, so the percentage of probably estimate of hepatitis delta around 3 to 6%. They give you a case of like around, depends on which one you look at, could be up to 22,000 by the modeling. So it's not an insignificant number of patients with hepatitis D infections. And again, since it's a very severe form of hepatitis, so definitely we recommend screening everyone with Hep B at least one time, universal screening. Next slide. Now, to prevent both hepatitis B and hepatitis delta, I think as Jennifer mentioned, we recommend universal infant immunization, ideally at birth, because that's the best time, because after a few years, they might be kind of already at risk of exposing to hepatitis B. So we recommend it to be done in all Canadian provinces and territories. Now, for adults, maybe the immigrants or maybe whatever reason they didn't really catch the immunization when they're young. So we also recommend universal catch-up vaccinations for all adults who have not got a complete series of Hep B vaccine dose, or even if they're not sure, it's good if they also not immunized to get the full series of the hepatitis B vaccine. Next slide. Now, shifting the gear a little bit, this session touched on about recommendation of a laboratory assessment of hepatitis B. So the first one started with quantitative hepatitis B DNA testing. So definitely for individuals with Hep B and on treatment, with a nucleotide or nucleoside analog, we definitely recommend to perform this DNA testing at least every 6 months to confirm continued adherence. Now, quantitative hepatitis B surface antigens. Now, we realize that not every provinces have access to this test, but hopefully in the next few years, near future, that most places will have access to do this quantitative hepatitis B surface antigen. And for those sites who have it, we recommend doing about every 1 to 2 years, which allow us to kind of monitor, especially very helpful, monitor response to treatment, and it determines someone if they're getting a close to functional cure. Now, we want to include some of the mention about novel biomarkers. So you can see some of the literature mentioning about some HBV RNA or core antigen. We realize that right now, they really don't have any kind of standardized testing platform and have not been really sufficiently studied to kind of comment how useful they are in clinical management. We definitely need more research on the using how best to use this biomarker when they are available. But definitely it's something to keep an eye out to focus on that I think in the near future, we might have that test might be available and can be used and help us to guide treatment response or predicting who might need the treatment. Now we realize that some community might not have all the access to testing, so especially for community that's have a more in remote area, that's a point of care testing for Hep B is recommended. Next slide. The last slide is talking about potential use of quantitative hepatitis B surface antigens. So one area is like maybe used in prognostic values. There's some research kind of showing this correlation that like the amount or the quantity of the quantitative surface antigen may be predicting, being helpful of determine if someone more at risk of fibrosis progressions or HCC development. In some way, kind of have to help us to stratify those patients at risk. There's some kind of research to show that it might be helped to identify the really true inactive carriers, especially those individuals kind of had kind of borderline kind of HBV DNA level or borderline high ALT. Also allow us to kind of monitor the response to treatments. So as you kind of follow more surface antigen done during the treatment phase, you can see that, oh, maybe it kind of dropped to the level that you think more likely they might get closer to functional cure. But the most research we have, and more to support the use of CONS-SEG, is to determine the probability of clearance of the surface antigens. There's good research to show that for the certain populations, especially among Asian less than 100, there's a higher chance that able to spontaneously clear the surface antigens without like a relapse. So kind of like more research, because as mentioned before, the guidelines are a living document. So as we know more about more research come out, we may be able to better use this quantitative surface antigen in our practice. Next slide. I think this one will hand it to Dr. Scott Fung from University of Toronto to talk about treatment for Hep B.
Great. Thank you, everybody. And thanks to the organizers for asking me to speak on these new and expanded recommendations for treatment of chronic hepatitis B. And so let's get right to it. So number one, all surface antigen positive patients who are cirrhotic, those with a personal history of hepatocellular carcinoma, and those about to receive potent immune suppressive, immune modulatory therapy, and as rare as extrahepatic manifestations are, all these groups of patients should receive oral antiviral therapy. That may not be particularly new. I think most of us were kind of doing that already, but now it's kind of firm in the guidelines as a strong recommendation. Number two, e antigen positive, e antigen negative patients with elevated ALT, just one time the upper limit of normal in a somewhat persistent fashion, and DNA over 2,000 IU per ml should also receive a treatment. That's not particularly new. I think all of us have already been doing that already. The new ones are probably 3, 4, 5, and 6. Maybe I should put a little star, a color, a different color to them. But now, e antigen positive patients who are over the age of 40, a little bit older, with normal ALT and DNA over 2,000. So basically, what we now call e antigen positive chronic infection, previously known as immune tolerant, should also receive antiviral therapy as a strong recommendation. And again, that's a new recommendation, different from the 2018 guidelines. Previously, we were just monitoring these patients. Next slide. Now, the number 4 is similar. It's kind of the younger immune tolerant group, e antigen positive patients under the age of 40 with normal ALT and high DNA who have a first degree relative with liver cancer or cirrhosis should also be considered for antiviral therapy. And they may be considered on an individualized basis because they are a little bit younger. And again, this was one of the newer, maybe more controversial recommendations. E antigen negative patients over the age of 40 with normal ALT and DNA over 2,000, now known as e antigen negative chronic infection, should also receive antiviral therapy in order to reduce the real risk of HCC in this somewhat older group of patients. And so this would encompass what we used to call the kind of the gray zone patients. These are probably the hardest ones to follow in your clinic because everything is normal. Their FibroScan is often unremarkable, and their DNA is starting to rise. So you worry a little bit about these patients. And so now, as our 5th recommendation for treatment, this is again a new and expanded indication. These patients should also receive antiviral therapy as a strong recommendation. And number 6, patients who are a little bit younger, who look a little bit like those in number 5. So the younger e antigen negative group of patients with normal ALT, but the viral load is somewhat a little bit worrying to you because it's above 2,000 and it's always kind of at that level, but their ALT is always normal. If they have a first degree relative with a history of liver cancer or cirrhosis, they should also be considered for antiviral therapy. Next slide, please. Number 7 are e antigen negative patients with normal ALT and DNA less than 2,000. So what we used to call the inactive carriers. These patients can be safely monitored, but again, the fallback is antiviral therapy could be considered on an individualized basis, kind of usually in the setting of perhaps immune suppression. But again, this is somewhat of a new, I guess we were doing this in the past as well, but generally it's safe to monitor this group of patients as well because their DNA is low and their ALT is normal. Number 8, those patients who have high ALT, but their DNA is below our threshold of 2,000 IU per ml, And we've always been looking to investigate these patients for other causes of elevated ALT. Dr. Ko just mentioned perhaps delta infection, alcohol, MASL, MASH. We always look for those, the usual culprits. But some experts who would also recommend antiviral therapy on, again, a case-by-case basis. And this is, again, a strong recommendation, but based on only level 3 evidence. And then lastly, we thought it important to really mention the importance and stress the importance of adherence to treatment. So if patients have patients with drug holidays, interruptions in their treatment schedule, usually due to things like loss of insurance coverage or lapse in their provincial reimbursement, for example, but they haven't met the usual goals of treatment, such as e-antigen loss, seroconversion, or perhaps reaching the quantitative level of surface antigen where we might consider stopping their therapy. Again, they should be informed of the important risk of flaring and the importance of regular monitoring after treatment is stopped in order to really catch those severe flares that could require prompt retreatment due to relapse. Next slide, please. So these are the recommendations again in the figure, the algorithmic representation of it. I won't go through all of it, but just to point out very quickly, again, the patients who are surface antigen positive with any of these high-risk conditions, it doesn't really matter what the rest of their ALT and e-antigen status or DNA is. You generally would just put these patients onto treatment. Those who have the high DNA, high ALT, not new, we're treating those patients. It's recommended as a strong recommendation in the 2025 guidelines, not too different from the 2018. Those with the low DNA and low or normal, subnormal ALT monitoring, again, not particularly new. What is new again here are those patients who have met the DNA threshold criteria over 2,000, but their ALT is normal or less than normal. You may now treat if these patients are somewhat older, than 40 years. They have more than really a mild degree of fibrosis on liver biopsy, should they have one. Liver stiffness measurement, FibroScan, 7 kilopascals, I should say. And if they are younger, below the age of 40, with a family history of hepatitis B-related cirrhosis or liver cancer, those patients may also be considered for treatment. And the fallback in the bottom bar here, all surface antigen patients may be considered for treatment on an individualized patient basis. So really the question always is your patient ready for treatment, and what is the right time for treatment? Is it now? Next slide, please. So I think Curtis touched on this briefly. Are the treatment indications evidence-based? And so I must say yes, but only partially. We always tried to rely on the best quality evidence where it was available, but it was not always possible, as you can imagine, for all indications. And some of the data we had to rely on to make our recommendations were somewhat retrospective in nature or based on sometimes modeling studies. And this is an example, thanks to Dr. Feld for this slide here. And from the systematic review, again, an example of patients who have low incidence of cirrhosis or HCC if their DNA is below 2,000 based on classic studies, which again were not always prospective and randomized. And there's a risk-dependent increase in liver cancer as you have increased the DNA level, as you can see in the chart here. And the evidence for a treatment benefit was always greater if the DNA level were a little bit higher. Next slide, please. Oh, and then the little insert there, I think these were from the CASL guidelines, and they kind of summarize kind of the state of the evidence so very nicely. Even if the effects of therapy on clinical outcomes cannot be consistently demonstrated for all subgroups to the highest standard of evidence to date, there are solid data demonstrating the positive effects of antiviral therapy that make future prospective placebo-controlled trials ethically untenable and impractical. Next, please. And so this is where, again, the voice of the patient is very, very important. And there are more and more studies now talking about patient-related outcomes. And we have data from our own Canadian Hepatitis B network as well, showing the importance of treating beyond things like DNA and ALT. And what is important to the patient, really the psychosocial impacts. Firstly, fear of disease progression. We hear that a lot from many of our patients. Financial loss, financial insecurity and instability. fear of transmission, transmissibility to others, particularly family members, stigma and discrimination in the workplace or in the community, and institutionalized discrimination as well. And lastly, from the patient perspective, really the hard to measure things like silence, solitude, withdrawal from friends and family, self-stigma, anxiety and guilt. Really, these are reasons to indications to treat in some patients that are extremely important on the individualized patient level. Next slide, please. And so first line therapy recommendations really haven't changed very much since 2018. But we now have set firmly the first line therapy that we believe should be available to all patients across Canada. Tenofovir alafenamide, tenofovir disoproxil fumarate, TDF, or entecavir are really recommended as first line monotherapy in patients with e antigen negative or e antigen positive chronic hepatitis B. That's a very strong level recommendation. TAF or TDF, with or without peg interferon, can still be considered in patients with e antigen positive or e antigen negative chronic hepatitis. And so I think there are very few patients who would opt for the combination regimen or payers for that reason, but it is recommended if accessible to your patient. Next slide, please. And so the reasons for choosing at least the oral NA therapy, which are familiar to many of you already in the audience, entecavir, TAF, or TDF, because of their extreme high antiviral potency, they're very low risk for resistance, almost close to zero for each of those agents, but not quite. Very safe, very easily tolerated by your patients once a day, very easy to take. And as of, I guess now, October 2025, they all should be available as generic medications. Next, please. And so this is, I guess, the next slide on how should we treat them? What are the endpoints of therapy? And so in patients who are e antigen positive, non-cirrhotic, the first endpoint, the intermediate endpoint should be e antigen loss or e antigen seroconversion, followed by at least 12 to 18 months of consolidation therapy, really to kind of prevent relapse when you stop these patients or when you draw their nuke therapy, withdraw treatment. In those who are e antigen negative and non-cirrhotic, again, we don't have the e antigen to look at in that case, so we treat until the patient has lost surface antigen in a confirmed fashion, or their quantitative level is below 100 in Asians or 1,000 in Caucasians, as Dr. Ko just mentioned, followed by 12 months of consolidation therapy. Now, all surface antigen positive patients should be closely monitored after stopping their nuke therapy. And an example would be monthly blood work for 3 months, then every 3 months for a year, and then once every 6 months in accordance with your usual standard of care. Again, in order to really catch any of these severe flares that may require restarting nuke therapy in these patients. In those with cirrhosis, then again, treatment can be of indefinite duration or until the loss of the surface antigen, followed by, again, regular monitoring. And so that's, again, at the discretion of the treater. Now, where did some of these data come from? I won't spend too much time. The RETRACT-B study was a study that was spearheaded and coordinated in Toronto, so there's a lot of Canadian data in this. It was multi-centered and retrospective, looking at e antigen negative patients, non-cirrhotic, who had had their nuke therapy withdrawn kind of at the discretion of their treater. And as you can see in the slide, on the graph on the left, there was a progressive increase in the rate of surface antigen loss over the 4 years of the follow-up at around 3% of 1 year up to 13% at 4 years. And so not earth-shattering numbers, but I think the trend was important. But at the same time, it taught us that there was still a risk of hepatic decompensation after treatment withdrawal, particularly higher in the cirrhotic compared to the non-cirrhotic patient population. So I think it's important because it does tell us there is a subset of patients who can do well after stopping therapy, but you still have to watch them very, very closely. And so this is the same algorithm here. Caucasian patients, once the level reaches below 1,000, you can consider stopping. If it's higher, please continue. For Asians, once they reach 100 or less, you may consider stopping. But if it's higher, then you'll most likely continue therapy. Next, please. So in the real world, the guidelines will now allow stopping withdrawal of treatment in patients before they lose surface antigen. But we know kind of at a real world level, most experts and treaters are probably continuing to go on for a number of years, but may consider stopping on a case-by-case basis. But please, again, to remember the importance of monitoring very closely after treatment is stopped before surface is lost. And for the future, we think is brighter ahead because newer therapies, in particular combination therapies, I think will lead us to higher proportion of patients reaching functional cure. Next, please. So the next two slides here are really the recommendations for HCC screening in hepatitis B. So monitoring for HCC is really recommended for all patients on antiviral therapy because there is still a residual but small risk of liver cancer. How do we screen? Abdominal ultrasound plus AFP every 6 months. And so these are the categories of patients that I don't think are that different from 2018. All cirrhotics, males over the age of 40, women over 50, patients of African descent over the age of 30 because of the higher risk of HCC, probably genotype related and perhaps related to environmental factors. Those with a first degree relative who have HCC and patients who are co-infected HIV, HBV. And you can use risk calculators to really help you better define those who are at high risk. Next slide. And this is what my final slide again shows us here when we compare with the EASL and ASLD guidelines. The EASL guidelines were recently published again in 2025. They remind us of the patients who are surface antigen positive at high risk. Those who have cirrhosis, definitely screen. Surveillance is recommended. Those without cirrhosis but who have a high risk of HCC, surveillance is recommended. Those who have lower risk, you don't have to do it. And so what's high risk and low risk? This is again an example of how you might better refine or define risk using PAGE and MPAGE-B based on the parameters listed in the chart here. But we made it easy in our guidelines. We still kind of go by the age and the gender of the patient. The AASLD guidelines will, I believe, be released in fuller form by the end of this year. They again remind us of those who have cirrhosis with hepatitis B are at high risk, definitely need screening. Those who are non-cirrhotic in this middle category here, again, similar to our own guidelines, should be screened once again. So again, remember screening for hepatoma in patients on or off antiviral therapy with hepatitis B. Those are our updated recommendations, and I think we will save the questions until the end. Thank you very much for your attention.
Great. Thanks a lot, Scott. Let it be noted that Scott is joining us from Hong Kong, so appreciate the level of commitment in delivering these guidelines.
Pleasure.
Before we continue, I just want to remind people that if you have any questions, you can put them in the chat box. We're also hoping to have some time at the end of the presentation to have an open Q&A with the audience. All right, so moving things along, we're now going to welcome Sébastien Poulin from Montreal, who's going to talk about co-infections.
Thank you, Curtis. I'm not in Hong Kong right now, but I'm actually presenting during Montreal Canadiens game, so it's worth mentioning. So I'm going to talk about the co-infections, namely HCV, HIV, and Delta. So starting with HCV co-infection, really nothing surprising or really nothing new. We start by saying that all HCV patients should be tested for HBs antigen and anti-HBC before starting HCV treatment. And then of course, all HBs AG positive patients, especially those with advanced fibrosis or cirrhosis, should initiate an oral anti-HBV NA therapy during the anti-HCV DA therapy. And then, again, nothing really new, but we mentioned that the HBs AG negative and anti-HBC positive patients with or without HBs should be monitored for ALT and HBs AG during treatment with HCV-DAs for up to 24 weeks post-treatment. And then also HBs AG and HBV DNA should be measured if ALT does not normalize or increases during or after the completion of the therapy. And HBV antiviral therapy should be initiated promptly in patients with detectable HBs AG or HBV DNA emergence with elevated ALT. So that's it for the HBV section. Next slide. Moving on to HIV. Again, nothing very, very new, except it's worth mentioning that we remove the words dual, using like dual HBV active antivirals, because biologically speaking, there's no point of using dual HBV active antivirals, even in co-infected patients. So the word dual was there before, probably just because the fact is that HIV drugs, they are the HBV active drugs are mostly combined together. So there's no point of having a dual drugs. And the 0.5 is also quite new because of the new drug cabotegravir. So we start obviously by saying that all people living with HIV should be screened for HBV infection and immunity. If anti-HBs and anti-HBC are negative, HBV vaccination should be done. The treatment with HIV with active antivirals against HBV should be initiated once the diagnosis of HIV and HBV has been established, regardless of the CD4 count. The monitoring during HBV treatment is the same as in the case of monoinfection. Remember that patients who have discontinued HIV treatment with active HBV antivirals should be monitored for HBV reactivation if they are unable to continue taking HBV antivirals. And then the 0.5, as you know, if you follow patients living with HIV, all patients co-infected with HIV and HBV start or switch to treatment with intramuscular injection cabotegravir for HIV should ensure that antivirals therapy for HBV is initiated or continued simultaneously, because this drug here, cabotegravir, has no effect on HBV. Next slide. And then probably the most important part in co-infections, the Delta. So about the Delta infection, we start by saying that all HBs AG positive individuals with anti-HDV positive antibodies should be considered for anti-HBV therapy, regardless of the HBV DNA levels or fibrosis stage, especially if the viremia is detectable. We know that NAs are not directly active against HDV, but in theory, they will block residual HBV replication that we could miss between the follow-ups, and which may reduce the risk of liver disease. Recommendation number 2, we say that PEG interferon therapy could be considered for 1 year in individuals without contraindications. But this recommendation makes less and less sense starting now, because new treatments are available, especially the bulevirtide that is now Health Canada approved. So we say that this treatment or others coming should be prioritized for individuals co-infected with HBV and HDV, with or without combination with interferon therapy, especially with those with advanced liver disease. And then, due to the high risk of rapid disease progression, all individuals co-infected with the Delta should be followed by the specialist and monitored closely with HBV DNA, HDV RNA, and ALT every 6 to 12 months. In addition, of course, to the HCC surveillance starting at age 40, as Scott just mentioned, and with annual fibrosis assessment. Next slide. And just a word about Hepcludex. It's called bulevirtide. As I said, it's now approved by Health Canada. It's a peptide. It's an entry inhibitor. It binds to the NTCP receptor, the surface of the hepatocyte. We know that it's very, very, very well tolerated. It's the administration is subcutaneous, 2 mg daily. It's a long-term treatment for the vast majority of cases. And if you want to know more about it, the study May 301, it was published in the New England Journal of Medicine and then presented elsewhere for the follow-up. But like the virological efficacy was approximately 75% effective. But again, it's a long-term treatment. So that's it for me. And next slide. Thank you.
Great. Thanks a lot for that, Sebastian. We'll now move along to Dr. Fernando Alvarez from the University of Montreal, who is our pediatric hepatology expert in the group. And he's going to, of course, talk about hepatitis B in the pediatric context. So take it away.
Thank you very much for the invitation to participate in these guidelines. We know that prevalence of hepatitis B infection are quite low in children in our country, and vaccination, testing to pregnant women for HBV markers, and now the tenofovir treatment in those women, pregnant women with a high level of replication are decreasing the vertical transmission, then still decreasing the prevalence in our hospitals. The incidence of cirrhosis in children are 2 or 3% of those chronically infected. Half of them will eventually have the risk development of hepatocellular carcinoma. In the next slide, we can see the natural history in pediatrics of the infection by HBV. You see a difference between those for the seroconversion of the antigen E, those that have received the virus by vertical transmission against those with were infected by horizontal transmission. Is a difference at time of seroconversion. Most of those with a vertical transmission seroconvert at the puberty, but at the end of the pediatric age, around 18 years, the level of seroconversion is more than 85% for the E antigen. In the next slide, we can see that the treatment, the pediatric age, hastened the seroconversion by 2 or 3 years, but at the end, again, of the pediatric age, 18, 85% more or less of those children infected at different times during the pediatric age will be anti-E positive. And the next slide, we see that the treatment doesn't change much for the surface antigen seroconversion. More or less 20% of treated or untreated patients at the age of 18 will get rid of the surface antigen and will get in the recovery phase. In the next slide, based on the natural history that we rapidly review, we have no evidence for treating children at the formerly referred immunotolerant phase or in the inactive phase when the HBV DNA is less than 2,000. However, we should consider treatment for adolescents with a metabolic associated fatty liver disease or type 2 diabetes, or those with a family history of cirrhosis and hepatocellular carcinoma. In the next slide, we propose to treat patients with an increased level of serum transaminases, and mainly those that show a decrease in the level of circulating DNA. Treatment should also be considered in those with advanced fibrosis and cirrhosis, and those that, even if they are antigen E negative, are showing a DNA of more than 2,000. And of course, all patients under immunosuppression or chemotherapy. And we do not forget those with extrahepatic disease associated with hepatitis B, or a co-infection has already been mentioned for adults. In the next slide, we see that children with at the formerly referred tolerant phase are followed once a year, and by ultrasound, ideally also a fibroscan, an alpha fetoprotein, ALT, and HBV DNA, and even if extremely rare, has been described patient with a hepatocarcinoma without cirrhosis. And after seroconversion, we propose to follow them more closely during the year following the seroconversion, be sure that it's no a relapse. In the next slide, finally, next slide, please. I think is the next speaker.
Yes.
Okay, good. Thank you very much, Fernando. And now, no hepatitis B presentation is complete without Carla talking about vaccination in little babies. So take it away.
Thank you, Curtis. So I won't read this in great detail, but just to highlight two main things that we updated in the new management of hepatitis B in pregnancy. One was that in the context of expanding treatment, as was reviewed by Scott earlier, that in women that have a high viral load, even before they conceive, you may wish to have a discussion with them about the pros versus cons of starting antiviral therapy earlier, so that by the time they conceive or are pregnant, they are well established and stable on antiviral therapy with the viral load suppressed. And then the second thing that was new compared to the previous guidelines was that tenofovir alaflinamide, or TAF, there's now robust safety data of using TAF during pregnancy. So either TDF or TAF could be considered for treatment for any woman during pregnancy if the indication is for active hepatitis, as previously outlined by Scott, so sort of standard indications. And as Curtis mentioned, we still reiterate the importance of giving the hepatitis B vaccine and HBV, and as well as follow-up vaccine serology. Next slide. So this is no change from before in terms of the threshold for starting antiviral therapy. So this is a viral load greater than 200,000 IU per mil to start antiviral therapy before 28 weeks or no later than 28 weeks. You could consider starting earlier. And after, if the indication for treatment is only to reduce the risk of mother-to-child transmission, you can stop antiviral therapy at 3 months after birth. However, in line with the overall concept of treating more or expanding treatment, you may wish to have a discussion with your patient about continuing therapy even after this pregnancy, just until all family planning is completed. So for future pregnancies, so that the woman is not starting and stopping treatment. We also continue to reiterate the importance of breastfeeding, and that TDF or TAF is safe during pregnancy and breastfeeding. As many of you know, entecavir is not safe during pregnancy. Next slide. And so finally, I wanted to comment on the infant vaccination and post-vaccinating follow-up. You will see an editorial or a letter to the editor in the Canadian Liver Journal, which we have responded to a comment about the timing of post-vaccination testing. The committee felt that testing at 1 to 2 months after the last hepatitis B vaccine dose, so therefore at about 7 to 9 months of age, was an appropriate time. that at that time there should be no residual surface antibody from receiving hepatitis B immune globulin at birth. And then finally, we also recommended doing it before 12 months of age and not at 15 months, as was noted in the letter to the authors, because by waiting that long, you could delay the diagnosis of vaccine failure. So please keep a lookout for our letter, and you can appreciate that. Next slide. So I'm not going to read through this. This is basically what I've just said that was presented in the algorithm form, and all of these slides will be available after the webinar for you to review. And next slide. The same thing. These are all the same management with the level of evidence for each one. And I believe that's it for me.
Great, thank you. Just before we conclude, want to bring everyone's attention to the supplementary table, where we spend some time talking about specific subgroups and management considerations. So this includes hepatitis B infected healthcare workers, hepatitis B in the context of underlying kidney disease, acute hepatitis B infection, decompensated cirrhotic disease, hepatitis B in the immune compromised population, and liver transplantation. So just want to make you aware of that. Next slide. As a reminder, there are multiple guidelines globally. And as has already been suggested, our Canadian specific guideline is quite similar to EASL and AASLD. The Chinese guidelines are a lot more aggressive as far as offering therapy, and maybe in the discussion session we can talk about the rationale behind that. And then we've already talked about the WHO and the focus on a much more sort of public health and lower socioeconomic setting compared to the rest of these very important guidelines. Next slide. So, a couple of important conclusions. Firstly, this document is available both in French and English, and it's can be found in the Canadian Liver Journal. It was published in May, so it's there for you and all your colleagues. The key highlights of these guidelines that we want to continue to emphasize is we're advocating for universal screening for hepatitis B, and in everyone who is hepatitis B surface antigen, we recommend hepatitis D screening, given the tremendously negative effect that hepatitis D has in individuals living with hepatitis B. We recommend universal and birth immunization for hepatitis B. And these guidelines have moved the dial in favor of treating more people living with hepatitis B in Canada. Again, this is we believe, a patient decision focused document. So with that, I encourage you to review the guidelines. Not only are they really important for guiding treatment decisions, but the first several pages is a superb review of hepatitis B, the pathogenesis, and will give you a real excellent grounding in hepatitis B. Again, before we turn it over to questions, maybe we can move to the next slide here. Want to again thank the audience who tuned in tonight. Thank you for your questions. I see we have a couple in the chat box. You can keep those coming. If you have questions, please raise your hand, and we'll get to those. Again, want to thank the committee for developing these. In particular, a special recognition for the two Carlas, Carla Ostaway and Carla Coffin, who really poured their heart and soul into making these a great document. And thank you to all of the support from our CASL team for the presentation today. So with that, we have about 20 minutes for a little bit of discussion. So I'll ask the first question as we're waiting for questions from the audience. Um, we've mentioned multiple times that we wanted to make hepatitis B, more available and more permissive. Can we ask the panel to get into a little bit more detail on why we feel that that's the right direction? Again, reminding people that if you are following Chinese guidelines, if you're surface antigen positive and over 30, the recommendation is to go on therapy, period, final. Um, so that's pretty permissive. We're not quite at that point. So maybe Carla, you can start off, and then the rest of the panelists can comment on that.
Yeah, I mean, I think there's a general trend in the field that we should be treating more. In my own practice, I use quantitative surface antigen to help inform that. So even if the viral load is less than 2,000, there's data based on the REVEAL cohort that if a quantitative surface antigen is greater than 1,000, that there is a higher risk of hepatocellular carcinoma. So that's what I use for counseling patients. And of course, it's, not everybody wants to take treatment. Not everybody is ready, and the adherence is important. So the most important thing is that you have ongoing monitoring, regular FibroScan, regular ALT. But that's what I do. And then if they have comorbidities, MASLD, et cetera, to talk about risk versus benefits of treatment. But maybe see what Scott would say about that.
Yeah, Scott, what's the quality of the data to support a more aggressive approach in these more borderline patients?
Yeah, I touched on it briefly, Curtis, for a time we didn't have to, we weren't able to go into each of the individual studies, but again, realizing that it's hard to classify patients all the time. And we know from many other studies, up to 30 to 40% don't really fit any of the old classifications. And many patients, even those who you could accurately or more accurately classify, sometimes didn't meet the more stringent criteria of maybe previous or other guidelines. So there was a recognition, I think, in the field that Carla mentioned that many of these patients are probably marching on towards a complication without us knowing, because we can't always measure ALT and DNA every 3 months for patients not on therapy. And so a lot of the data is kind of retrospective. A lot of it is from, again, East Asia, where they're able to follow larger cohorts of patients untreated for reimbursement reasons. That kind of informed a lot of that decision making around, I think it was recommendations like 4, 5, and 6 in the guidelines, or at least for these gray zone E negative patients with the persistently normal ALT and not much else to talk about other than just a rising or a persistently high viral load. But I do agree, surface antigen, if you have it available to you, is great to help stratify some of these patients. But we were often asked why we didn't use surface antigen as a treatment indication threshold, and again, largely because the data aren't as strong in that area, and it's not widely available across the country.
Okay.
Although Carla's right, there are data to support its use as an indication for therapy in some patients.
Sure. A question from the audience, both from Roger Sandri and Sergio Borgia, a couple of my infectious disease colleagues, and they have a same question. And this is again focused on treating sort of more gray zone patients. So you have a person whose Hep B viral load is below 2,000 and their liver enzymes are below the upper limit of normal. Does treating those people actually reduce their HCC risk? Maybe Hen can start, and then the rest of the
Yeah.
panel can comment.
I don't think we have enough data to support treating even the what's so-called inactive carrier? Because I think the first step we should do better, I guess, based on our previous study, is that people clearly should be indicated for treatment. There's still a huge portion that not got treated, of course, for many reasons. I think, of course, it's a shared decision with the patients. As sometimes I do feel strongly a patient need to be treated. It's still the concern about indefinite treatment until we get better agents. I think it's the uncertainty, even the medication quite safe. I think it still needs to be buy-in from the patients. And I understand hopefully in the near future we have better drugs. So I think the first step we probably should treat more that really needs to be treated. And I think also highlight the importance about screening too, because I clearly have patients on treatment doing well, undetected but viral low, that also can develop HCC. It's really rare. So I think it's very important that, yeah, even we treat them, we lower the risk of HCC. It's not nothing. So I think just highlight that that part is very important. It's really rare, but I think we definitely all have cases that they got treated doing well and still have HCC.
Okay.
I think it feeds into Carla's response. If you have 100 E negative inactive carriers and they're all the same because they have low DNA and normal ALT, then use surface antigen to risk stratify. Right, Carla? And then we'll see the ones with higher surface, maybe above 1,000, maybe then you can use that as a way to predict risk of HCC, because that's all you're really doing at this point is kind of managing risk long term.
Yes.
Yeah.
Yes. Yeah.
I see Carla has put in a reference or two here for the audience to review if you're interested. Okay, so Dr. Borgia, I see you have a question. The
Yeah,
floor is yours.
thank you. Thank you. Wonderful presentation. Hi to everybody. Nice to see everybody again. Thank you for the invitation. One of the interesting things about the gray pair patients with the normal liver enzymes, the recommendations, Scott, as you mentioned, particularly 4, 5, 6, but particularly 5. One of the challenges I'm having since this summer is the patients have been following for quite a long time. The new patients, it's a bit easier because there's no sort of therapeutic history relationship wise. But the patients that have been following for a long time, I'm now introducing the concept of thinking about going on therapy. Of course, their first question is how long, and then that's a whole can of worms, and they're not keen on the indefinite answer or the lifelong answer. And they kind of seem a bit confused that I've been following them for however many number of years, and they may have just ticked over 40 or they're in their early 40s. And they say, well, I'm the same person. Nothing really has changed. You didn't treat me. You told me everything's fine for the last 5 or 10 years, but now you think I should go on therapy. I'm struggling with that, and that's not a small number of patients in my practice. So that's one question or comment that I would make, that I'd be interested to hear how people are navigating that. I know we can individualize it, but then at the end of the day, the aggregate sum total of your practice, you don't want to sort of not be following guidelines. And my second question is for women who are approaching or are at or just over 40 now, and are having continued family planning and children, and we wouldn't have been treating them before for the purposes of vertical transmission prevention. There are going to be quite a few of them who have perhaps low viremia, certainly not 200,000, but log 3, low log 3 with normal liver enzymes, and they'd be eligible, but they're also pregnant. And would the committee recommend treating pregnant women who would be in that gray zone type of category, who wouldn't meet the strict indications for the prevention of vertical that we would have done before? That's my second question.
Okay, Sergio, maybe the first one I'll tackle a little bit. You're right. These patients have been with you for many years. The only thing that's changed is maybe they're just getting a little bit older now. But how I usually approach is I tell them kind of the evidence has changed a little bit more, that we have more data on these patients that we didn't have before. And I think probably virally suppressing a patient long term, if they're good for long term therapy and compliant or adherent, then I think in the end, it'll probably be easier to cure a patient like that. But it's hard to know for sure. There are some studies that show treatment-naive patients may respond to some of these newer combinations just as well as the virally suppressed. But I'm often surprised when you kind of bring the voice of the patient back into it, and then you say, I've been following you for 10 years. And then they've always said, "Oh, I wonder why you haven't treated me for the last 10 years." So sometimes they put it back to you, and I'm usually kind of a little bit surprised when that happens. I think it's kind of all happened to us before, but it
Right.
probably is an individualized decision. But I usually talk about what the evidence now, what we now know compared to, say, 10 years ago.
And also,
Thank you.
Scott, there's never like real emergency to start a treatment, right? So I've seen a lot of patients like Sergio, and I prefer to wait because it's never good to start a treatment in someone who's not sure. We want to have good adherence. So if it's not on the first appointment, the next appointment, the third one in 2 years, but every appointment you talk about it, and sometimes they change their mind.
Yeah. If I can maybe address your second question, I mean, I think it's more as we were saying, it's a shared decision making. And the way I put it is often you're basically it's getting older, right? I said, and that like many of us, as we get older, you're screening for colon cancer, you're screening for breast cancer. And so this is another sort of cancer preventative approach. And for women, I don't think it's an urgent thing. Like if you're during the pregnancy, if they don't want to complicate things, I said we can have this discussion after the baby is born. If they're concerned about taking treatment, I mean, adherence is important. But I also use quantitative surface antigen to inform my counseling about whether or not you should take treatment or not. And I think there was a question about the childhood vaccination in the chat earlier on, and I thought maybe we should address that too for the person who put that question in. And maybe Jennifer might answer that. Will they have the vaccines available in Ontario for children, for infants?
Thanks, Carla. I answered in the chat just a second ago, but unofficially we have heard that although everyone knows it should happen, and it will probably happen eventually, it does not currently have the political will to prioritize it at this time. However, we are also talking to NACI, and by we, I mean a broad coalition of people beyond Action Hepatitis Canada, to have NACI review their recommendations as well based on evidence out of Ontario specifically. And so we have our fingers crossed on that one. Nothing moves quickly, but we keep working on it.
Good. Thanks, Jennifer. I have a question for Fernando. And again, it gets back to treating more people and treating them at an earlier age. Now, just because of the nature of your practice, you're starting, children and teenagers on therapy. And is there any evidence that these young individuals, because they started on therapy at a much younger age and then stayed on therapy, ultimately have lower risks for HCC and advanced liver disease compared to somebody who doesn't start on therapy until they're 45 or 50?
No, it's not. Actually, it's not real evidence. Chinese people and the Chinese guidelines are also very aggressive in the treatment of children. They pretend that if you treat with PEG interferon associated with nucleoside analogs, you get faster and complete recovery with also surface antigen associated seroconversion. However, for our guidelines, I revised all those papers, and I have the chance also to be a reviewer for the Chinese guidelines. I was very critical with those guidelines because when you read the papers, they are not very rigorous, and on the other hand, they treat patients with mixed patients with high level of ALT with those that don't have or have normal ALT levels. On the other hand, we should mention that PEG interferon in small children with a brain in development, I don't believe is a good indication.
Good. Thanks for your thoughts on that. Getting several more questions here. So there's one question related from Xavier. about the use of FibroScans and the frequency of that. Who wants to tackle that question?
It was not addressed in our update, but in 2018, the recommendation was every 2 to 3 years. So I believe we would still recommend that. If you have fibrosis at the baseline FibroScan, you could repeat maybe a year after every year. And then, as Carlos said, if you don't have access to FibroScan, you can at least use FIB4 and other markers.
Okay, good. Thanks. I see Jennifer put a comment in about the status of TAF across the country. Do you want to just expand on that for the audience?
Sure, thanks. Vemlidy was approved by Health Canada and received a positive recommendation from CADF at the time in 2017, but the company and the provinces through the PCP were not able to agree on a price. They have revisited that this summer, and so Vemlidy is now becoming available onto formularies. So it's available in Quebec and Nova Scotia right now, and the NIHB and Veterans Affairs formularies, and feel free to ask your provinces, your provincial formulary managers when they will be adding it, because that's sometimes how these things happen. And we're working on that as well whenever we're meeting with them too.
Good. And thanks for your work on this front. Carla?
I have a question for the committee. So now that you might, as you guys know, that EASL had put in their guidelines that for post HCC treatment, like secondary chemoprophylaxis, tenofovir or TAF might be better compared to entecavir. What do others think? Because we in our guidelines we said first line entecavir or tenofovir. What do others think about that recommendations, and should we almost be publishing a update or modification to say that for HCC patients we should be recommending prioritizing TAF?
Well,
I guess my philosophy on that is don't let perfection be the enemy of good. Being on any therapy is better than not being on anything at all. I think we have to recognize that the literature is not entirely consistent across the globe, and may differ between different populations as well.
but what if the costs were the same?
Yes,
So
that's what I mean.
All the costs the same, would entecavir still be in the first line? I think it's a matter of cost mostly.
Especially go ahead.
Sorry, Carla,
Go ahead.
I still don't, I know we definitely see the pattern in some of the study, but I still don't know how mechanistically, like why that agent seems to relate it with lower HCC rate. And even the more confusing part is like some studies show the TAF is even lower than the TDF. So I think maybe more like the pro-drug is more direct drug that works, but I still don't kind of quite understand. And even I asked that question to Dr. Lambertico, I don't think he can give me an answer to say why TAF looks like lower the risk of HCC. But I kind of agree with Curtis. I think the key is like we really want to lower the HBV DNA. And I do use a little bit more TDF. Mainly, I just have some people not sure they got exposed to treatment before. They're not sure which agent when they're in other countries. And I just worry about resistance. So I select a little bit more the TDF before. But I think as long as the DNA is lower, I think we are helping to lower the risk of HCC.
Yeah, I would agree. We're lucky to have representatives from EASL and ASLD recently in town, and the experts could not agree on which one was better. And so maybe, Carla, it's an opportunity for us to look at in the Can Hep B network again. We probably have most PDF patients.
Yeah. We don't have TAF, that many TAF patients, but just, because of that data, the little thought that if we do have TAF available, post HCC resection, ablation treatment, the secondary chemoprophylaxis to prevent recurrence of HCC, perhaps we should think about TAF might be better.
just something to consider in the context of HIV hepatitis B. Historically, before there was combination antiretroviral therapy with tenofovir, they had a very high risk of HCC. Um, we start our patients living with HIV on therapy immediately, so they get treated younger. And these days, most of the key regimens that we use include TAF. And frankly, we almost never see HCC anymore. So, as far as sort of not robust, but sort of your clinical impression, uh, early treatment, universal treatment, and TAF containing regimens certainly seem to benefit people living with HIV, and I suspect some of those principles extend to hepatitis B monoinfection as well. Hmm. Okay, well, that was a very fast 90 minutes. We covered a lot of terrain. Again, thank you to all the participants and for your really insightful questions. Thank you to the panel for excellent presentations and a really great discussion. I encourage everybody to go out there and download the guidelines and uh, and uh, and review them frequently. I think they're really useful for improving the lives of our patients living with hepatitis B. With that, I will bid you all a good evening.
Thank you.
Thank you.
Thanks, everybody. Thank
Have
you,
a good
Curtis.
night.
Thank you.
Very much.